All right, everybody. Let me get this all set up and good to go. Perfect. Well, hello. I haven't jumped on one of these in just a tad, so that's why I was just going over and setting it up. I just want to make sure everyone can hear me. I know before I had some audio issues, but I'll go ahead and start. So, as a reminder, my name is Chet Donnelly. I'm a spine surgeon here in Dallas, Texas, and I usually jump on these lives every now and then, maybe for 20 minutes or 30 minutes at a time, just to go over different topics in spine surgery. Appreciate everyone that kind of jumps on. I'll try to get to all the questions. As just a friendly reminder, just remember I can't give any specific medical advice, but I can answer some general questions. Some of the things I want to talk about today are these spine cages, spine surgery cages. That's a big deal in terms of spine care. I'm going to respond to some of your questions. So let me get some of my props out here. And a couple of things we're going to talk about is spine anatomy. The key thing I want to talk about, it goes bone, disc, bone. And in terms of different conditions you can get, one of the big ones is called spondylolisthesis. What is spondylolisthesis? It is when one bone slides forward on the other, just like that. In general, there's two types of spondylolisthesis. Well, actually, there's six types, but the overwhelming majority of people that have spondylolisthesis get it from one of two ways. The first way is from a degenerative type, and that's when in the back part of the spine, you get like a pointer here, in the back part of the spine, it goes, here's the spinous process. So like if you feel your neck and the pokey things on your neck or the pokey things on your back, those are the spinous processes. Those are what you're feeling here. Well, just deep to those are the facet joints. These are the joints for when you are moving back and forth. It's like the knee joint of the spine. That's one of the major sources of back pain. That's one of the major sources of arthritis. Now, the way that works and the way that that really hurts you is when you get this wear and tear arthritis on the spine. That can cause pain. If it gets to be severe enough, you get this medical word called spondylolisthesis, and that's when the bones slip forward. If it's the degenerative type, the majority of the time that's at this bottom part here at L5, S1, L5, S1. There's another type called a pars fracture, and that's what this model shows. So when this bone is kind of just wiggling in the wind, so the joints are actually perfect because they're not really connected to the rest of the spine. This spondylolisthesis, where you have a pars fracture, it's called isthmic spondylolisthesis. It could also be from a traumatic type. That also causes this instability. 88% of the time, it's at 5-1. You can also get it at 4-5 and about 11% of the time. And then that other percentage, maybe 10, is from the L2 all the way down. I've definitely treated a couple of them surgically at L3, L4, and those are great because 3-4 gives you like a million different ways to treat it, whereas 5-1, there's kind of two ways to treat it. 4-5, there's two or three. It's a little about patient's anatomy and the minimally invasive skill set of the surgeon. So just to reset one more time, I'm a spine surgeon here in Dallas, Texas. I do everything from the neck down to the pelvis. I jump on these. I used to do it a lot more frequently. Now I'm doing it maybe once a month, but I'm going to try to do it a little more often and go over different topics. The things I'm going to go forward and over today, and I'll probably only be doing this for about 20, 30 minutes. So please follow. That helps you not miss the next one, is anatomy of the spine, bone, disc, bone, the nerve tunnels, spondylolisthesis. What is that? A disc herniation. What is that? Treatments for these. I want to talk about fusions. This is a very fancy high-tech fusion cage. I'm going to tell you why fusions stink, but also why fusions are amazing. It's like, how can they both be true? And I'm going to tell you that also. We're going to go over disc replacements. Here's a giant model of a cervical disc replacement. Here's the actual size of a disc replacement. So a ton of topics. And I'll also try to get to your questions. So I'll go over topics and I'll get off tangents and I'll get to questions. So let me kind of jump to a couple of these questions. I got a couple different platforms going, and let me just rip through some of these questions and then I'll get back with everyone. I appreciate all the likes coming through. That helps promote this to your peers. Let's get those likes up. There's other people maybe going through the same issue as you, and the algorithm helps then tell the world this is a good video and helps people. So let me rip through a couple questions, then I'll get to some topics. From Rick, he says he's fused 5432 S1. Would you recommend with a broken S1 pedicle screw? Well, if you have an S1 broken pedicle screw, so that means you got a big fusion here. It's likely you have all the stress down at L5S1, and that L5S1 probably hasn't fused or didn't heal. And during that time, the stress broke that pedicle screw. If you're asymptomatic from it, it's fine. Your body may be still fused even after that fracture. If it hasn't fused and you're still having pain, then you have a non-union at 5-1 and you need to be extended probably down into the pelvis. But that's not my formal advice. I'd kind of need to see your case. How to use the MLD procedure with the ultrasonic device. So the MILD procedure, mild, stands for minimally invasive lumbar decompression. It's kind of a long topic to describe that. Pretty much that's a term for, it's kind of a marketing term. I'd kind of say that it's where it's something that created by spine surgeons that now pain doctors use. So I'm not against the mild procedure at all, but if you're going to have it, if you're going to get it done, if you're going to search it out, make sure a spine surgeon is doing spine surgery. That'll be a big theme I keep talking about on my social medias is I love chiropractic doctors. I love pain management doctors, but spine surgeons should be the ones doing spine surgery. So the mild procedure is one that pain doctors sometimes do. And great if everything goes great, but if there's any hiccup, I mean, they'd have zero idea how to fix a dural tear, zero idea how to fix instability. It's just boggles my mind sometimes that, anyone could do spine surgery in a way. What the mild procedure is, it's a small incision, maybe that big on the back. You go in and they're just kind of cleaning out this area. It sounds as simple as that. It's not 100% that way. In terms of the ultrasonic device, I use the ultrasonic bone scalpel all the time. There's probably many people in America, I don't know the total number that do. It's a great device that use it. From Raj, hey doc, hope all is good. Still suffering from neck pain. Had my MRI a few days ago, said it'd be normal. However, it feels like just cracking. Could the cracking be causing pain? Maybe, I'm not really sure. Next question from Mo3RB. Endoscopic versus microscopic surgery, which is better? All the medium and short-term data has shown that they're about the same. Long-term data, they're 100% the same in terms of endoscopic versus microscopic. Again, we're kind of debating between an incision the size of my thumbnail and the incision the size of my pinky nail. It's a 18 millimeter incision versus 8 millimeter incision. So if anyone at home smart enough to know the difference of 10 millimeters, that's what we're debating. And I'll just kind of leave it at that. From Chrome Mondo, if I choose to get a microdiscectomy, it doesn't do well. Can I go ahead and get a total disc replacement after? The answer is yes. What causes numbness of both legs at night? I'm not sure, my friend. From Diana Pope. I don't know. There's a whole lot that it could be. All right, let me get some questions over here. Move the camera. Can't see it perfectly. Sorry. So from I Love Pretty, they went through the neck to fix my spine. Yep, that's probably called an ACDF or a disc replacement. Extremely common, probably my two favorite surgeries. Some doctors only do neck surgery just because they have such great outcomes. That's when you go through the neck, you push the esophagus to the side, you clean out the disc material, and you either put a disc arthroplasty device like this one shown here, disc replacement device. This one's the Mobi C. This model here is the Simplify. There's a couple other models out there. I just don't have them. Or you could get a 2-level or 1-level. This is a 2-level shown. Something called an ACDF. These really are fantastic. Fusions get a bad reputation, but they really shouldn't. There's short-term, medium, and long-term data that patients that need surgery for the right indications do fantastic, and like they get their life back, and they do wonderful from neck fusions. Just reading some of these comments. I use the rounded neck pillow for 8 hours and avoid a hunch neck. Okay, that's great. Got people sending me gifts. Big Will, I appreciate the gift. Don't send me gifts, though. I only kind of jokingly say that is save your gifts and your TikTok money for other people out there trying to make a living on TikTok or people in other countries that are kind of jumping on. And, that's a huge source of their income. I just do this just to educate and kind of help promote my own name. But so appreciate the gifts, but don't waste your time or gift money on me. How about that? Another person asked, what are you holding in your hand? This is a cool cage. It's from Evolution Spine. I like this cage a lot. It kind of goes in through the belly, and you can go at probably anything from L1 to L5, but the majority of it goes at L5, S1 is where the majority of these cages go. How do you feel about nerve ablations from TMD? I like nerve ablations. I don't do them personally. I send those out to pain management doctors that I partner up with. They're good for back pain. They're not great for shooting down pain. From Teeny, I have foot drop due to nerve damage. Can you explain Microdisc 3 later. It's probably at L5 S1 or L4 L5. Foot drop is usually the L4 nerve root. That could either be at 4-5 or 5-1. Pretty much injury to the nerve causes the tibialis anterior muscle not to function properly. So let me have you been keeping up on your mewing streak? I don't know what that means. Is there a minimally invasive L5 S1 fusion? Yep, that's what the majority of the fusions I do. They're minimally invasive fusions. From Texham, is a 2-level disc replacement dangerous? No, not at all. Actually, there's great 10-year data in the Journal of Neurospine published in 2020 that looked at 2-level disc replacements. So let me kind of back up and show you. So in terms of this disc replacement right here, it's the MobiC. We have 10-year data published in 2020 in Neurospine that showed 10-year outcomes of 2-level disc replacements compared to 2-level fusions. Don't get me wrong, 2-level fusions are still great. They're still the gold standard for multiple pathologies. But what the rates showed is at 10 years, the rates of needing another surgery for a fusion could be anywhere from 10 to 20%, whereas the rate of needing another surgery either at the index level, so the level you had surgery on, or the level above, was 4 to 5%. Patient outcomes were fantastic with 2-level disc replacements in the neck for certain pathologies, soft disc herniations, maintain correction of the spine, maintain facets. A 2-level disc replacement is a fantastic option to treat 2-level disc herniations in the neck. So I really like it. That's a paper I cite all the time. That's a study I cite all the time. It was a 10-year outcome study on 2-level disc replacements. In terms of the lumbar spine, I don't know if there's 10-year data on 2 levels in the lumbar spine published here in America. The only reason I say that is there's different they're called IDE for inclusion device exemption experimental. Let me think what IDE stands for. Pretty much when we do IDE studies, that's when we are doing kind of new technology, and you have to follow very strict guidelines. That's why certain new technologies do great when they're first coming out, because the surgeons in that study group, and I've been a part of those, they follow very strict guidelines. And it's only when others are trying to use the technology that maybe don't follow those strict guidelines is when they kind of not cut corners, but maybe they do that surgery on a smoker, or maybe they do that someone on severe neck pain and severe neck arthritis. And those aren't the best outcomes on that. From Sent from Heaven, how could I straighten my spine? Well, you don't want to straighten your spine. You want curvature in the spine. You want something called lordosis, a curvature back here, both in the lumbar spine and in the neck. I don't have a neck model here, but you want lordosis. So that's why cages such as this, if you can kind of tell, is like a wedge shape. I don't know how many degrees this one is. This one's probably 8 degrees, but a lot of the cages I use can be up to 15 degrees. So let me just reset. Appreciate all the likes coming through. Appreciate the shares. That really helps push this to your peers, push this to those going through some of the same issues you have. I hear from a lot of people, not to speak for y'all, but they've had neck pain, back pain for years. Their doctor doesn't really communicate with them as well, or maybe they just see the PA, and the PAs are great. I love PAs. They're really important. But it's a really big deal to be able to sit down with your doctor and talk to your doctor. That's why social media is kind of nice, because, I'm able to talk to it's probably gonna be 10,000 people at the end of this 30-minute period about different spine pathologies and go over different spine issues. So it's just kind of a nice way to connect with the doctor. Going over a couple things, and sorry, there's so many people in the chat. I know I'm not getting to all these questions. Again, if you direct message me, that's another way you can connect with me. I'm extraordinarily likely to have my staff give you an automatic reply of just kind of saying, if you want to do a telemedicine consultation, I do about 20 of those a week. New patients all the time. You need x-rays and MRI. The number one thing patients don't have, and I don't understand how I can emphasize it more, is you need x-rays, because I'm just going to talk to you and say, let's do x-rays and follow up. So you need x-rays. Go to your doctor, get the x-rays on the thing. What are vertebral hemangiomas? From Cheryl in Great Britain. So Cheryl, those are essentially instead of having bone throughout the entire bone and spongy bone, there's like an area where it's almost like spongy blood. And that's a hemangioma. It's a collection of bloody bone, or blood instead of bone is the simple way. Hemangiomas are almost always totally safe, but I can't give advice on that. Can a foot drop heal? Yep. I've had a lot of patients with foot drop that maybe didn't want to do surgery, even though I'd advocate to do surgery if you had foot drop. And some of those do get better. And I've also had, shockingly, some patients who they saw me and they said they've had foot drop for more than a year or two, and we do surgery. And I said, I don't think it's going to come back. And it does come back. And those are the ones I wish I made a video on beforehand. And I'm going to try to be a little bit better about that, just to kind of share their story. How does this head stay on your spine? Sheila, no one's ever asked me that question. That's kind of an interesting thing. Well, it stays on your head through a bunch of ligaments that are in the skull, that are in the, I don't think I have my bigger spine model here of the neck. Okay, they're in your skull and they attach to your head. So interestingly, because our cars are getting safer and because our trauma is getting better at identifying things, because we're better at humans at keeping people alive after major car accidents, we actually see a lot more, they're called internal decapitations. And that's as gruesome as it sounds, where your skull separates from the C1 bone, and normally it's, you die, and it's still a very high death rate. That's crazy tragic, but we have better technology now to identify it, to treat you at the scene, and then to keep you alive to where we can surgically stabilize that in a trauma setting. So that used to be pretty much, if you had that, you were dead. But there's so many patients now that show up, they're paralyzed. I mean, it's a big deal, don't get me wrong, but it's just a condition that used to be associated with more like total mortality. But because cars are getting safer, people are surviving these extreme injuries. And so essentially, how does our spine stay on our head? It's attached at the skull and C1 through a bunch of ligaments that could become ruptured in a severe trauma. And the term is internal decapitation, as gruesome as it sounds, because that's kind of what it is. And it's a terrible, terrible thing to have. From Texam, are there different different sizes of motion sparing devices? How do you determine what size goes in? Wow, that's a great question. There are different sizes. In general, most of the implants come in different footprints in terms of how fat they are, side to side and back and forth. That kind of like a large, medium, and small. And then once you have that figured out, there's different heights, and usually they have 3 different heights. It just depends on what the implant is: 7 millimeters, 5 millimeters, right around there. In terms of how to do it, some of it's based on gender. In general, men have larger cervical spine bones just by several millimeters, and so they get larger implants than females. And then height, you try to match to the other height. That was one of the things that us spine surgeons learned a lot about: the disc arthroplasty, the disc replacements. We don't want to overstuff. You don't want to put too big of a one into that disc space. From Helen Zhang, my surgery was May 2024, disc replacement at one level and a fusion at one level, then a disc replacement one level. After a month, feeling left-sided arm, hand numbness, tingling, and shoulder. So I'm not sure exactly what that comment means. If that means you're great and you did well, that's kind of weird. So it's disc replacement, fusion, disc replacement. If you really think about that, that's an interesting X-ray to have seen before you had surgery to see how that was indicated. But it sounds like you're doing great. Another question from our gal Sal Nola. I had 2 spine fusions with new technology. I would have loved to have had surgery where I could move better and bend. Thank you, Sally. For sure. Okay. Next question. Stan Wolf. How do you perform surgery with the ultrasonic device for spinal and bone spurs? Good question. Making long story short, the first part's similar to a lot of the other spine surgeries people do, where you have a small incision. Just depends. I usually say it's like the size of a credit card. Incision on the back. I peel off the muscle. I'll do a very minimally invasive subperiosteal dissection, pull the muscle back. And then the ultrasonic bone scalpel. I don't have a model here, but I have tons of videos both on my TikTok and Instagram and YouTube of the ultrasonic bone scalpel. Essentially, it's a blade. It kind of looks like a knife, and it's kind of like a dull knife where it'd be hard to cut my skin with it on face value. But when I hit a pedal, it vibrates at a certain like 10,000 or 100,000 frequencies. It vibrates these crystals, creates enough heat to where it melts bone. It matches the modulus of elasticity, but it doesn't cut skin. It doesn't cut nerve tissue. It can burn it, but it has high power irrigation. So it's like you'll see in my videos, it looks like one of those irrigation machines is going off. So it's a really wet device to keep it cool. So it doesn't hurt soft tissue. It just kind of melts bone. So you melt the bone and then you can remove out the arthritis. I don't know if that was like the best description of how do I use the technology, but that's how the technology works. Instead of using a burr that it looked like this and there'd be a little ball tip, it's usually a 3 or 5 millimeter ball tip on the end of like a drill that spins at usually mine's about 70,000 revolutions per, gosh, I don't know if it's per minute or per second, but I have it at 70,000 and it spins at such a high thing. And, you can imagine if you hit something wrong, it spins it up and, it spins up all that spaghetti noodles and you don't want that at all. Whereas the knife doesn't cut soft tissue. That's just how it works. So the technology of how it works is a little too smart for me, but I have multiple videos showing that it won't cut my finger and it'll cut bone and it just has the same modulus there. So that's kind of how it works. I hope that answered your question a little. Some people are asking, who am I and what am I talking about? So just as a recap, I'm a spine surgeon in Dallas, Texas. I jump onto these for about 30 minutes, maybe every other weekend, a couple times during the week to answer different questions about spine surgery, spine care. I go over disc replacements. I go over spine anatomy fusions. I do telemedicine all the time in my office here in Dallas, Texas. I'm in a 5-person, about to be 6 in November, but in a about to be 6-person spine surgery group. We do everything from the skull down to the pelvis. We also do non-operative spine care. So it's a great way to kind of take your life back and not have to deal with all the terrible issues that getting older causes, such as degeneration and things like that. I need to check one thing on my phone, so everyone stay put. Okay, perfect. Just wanted to see if I had any new text from my wife. We have 2 kids napping right now, so I have to kind of stay on board on that. Another question from user and then a bunch of numbers. Can disc problems cause thigh pain? Okay, I have a special guest. Munchkin.
What?
You can. All right. So special guest who really wants to be featured. This is Jack, and he is very excited to be featured. He's creating all that ruckus back there, but he wanted to come say hi also.
Hey. Yeah. Cool.
Cool. Anyway, we love him to the world, to the moon and back. So if you hear all that ruckus in the background, that's gonna be him, but he's having his little quiet time. No, I'm not doing that. Anyway, so let's get a little back to business here. So from Jeffrey, can you explain moderate to severe spinal stenosis? My favorite thing to take care of and one of the best outcomes in terms of spine surgery and even non-operative care. Let's break down what that means. Spinal stenosis, Jeffrey. Spine is the spine, and this can be in the neck or the lumbar spine, but there's kind of 2 different issues. The neck is where the spinal cord is. Actually, in your lumbar spine, it's just a sac with a bunch of nerves running down it. And that's 2 different things that most people don't realize. If you get punched in your spinal cord, cells die, you're paralyzed. If you get punched in your thecal sac, it hurts, but those cells are okay. They're just different types of neurons and cells. The reason I say that is it's totally different pathology in the neck and the thoracic spine versus the lumbar spine. So spinal stenosis, if this is the spine, so neck, and you look down the tunnel, here's the bone, here are those spikes you feel in your back. These are all the nerves are running down, and there's different things that can squeeze these. In general, it's 3 things. It's either something called spondylolisthesis, so it's instability, one bone moving forward like that. It's these joints getting very thick. That's arthritis, just like you get a callus formation on your hand. And that thickening can grow out here in the muscle. That's fine, not a big deal. But when it grows inside, that starts squeezing the nerves, pinching the nerves. Or you can get a disc herniation. So you get, everyone kind of knows what disc herniation is. Like here's the disc, and if it gets a rip in it, could push out the front, the side, not a big deal, but it would push out the back, hits the nerves, numbness and tingling shooting down could be a symptom. So that's what spinal stenosis is. It's squeezing. In terms of mild, moderate, or severe, well, there's different radiologic classification systems. If you can, you can just think about it yourself. Mild is probably just a little. Moderate is about 50%, and severe is more than 50% is one of the classifications. Or they break it into 2/3. That'd be like 66%. That's a way to think about mild, moderate, and severe. But look, just because you have severe spinal stenosis doesn't necessarily even mean you need to have surgery. It's based on the symptoms. Now, in the neck, it's a little different. If you have severe spinal stenosis in the neck and you have balance issues, if you have myelomalacia, if it's progressing, if you fill out something called an MJOA score, that might be something to where you need spine surgery even before it gets bad, but that'd be just the neck. And that's, I wouldn't say it's rare, but it's not all the time. I'd say what's more common is I see patients with severe spinal stenosis in the lumbar spine, and I say, let's just keep an eye on it. There's no need to do surgery unless it flares up. And there's pretty darn few people that talk me into doing surgery. They're like, I just want to be done with it. I don't want to worry about it. Fine. Most people we just keep an eye on, and when it flares up, then we take care of it. What symptoms indicate surgery? Not enjoying your family, the pain that limits you, not going on trips, not able to help around the house, not able to help out with laundry, groceries, because the pain is so severe. Trying physical therapy for a while and that not working. Most patients get better at physical therapy. Not able to have steroid injection and get reliable improvement for that. A lot of people don't want the drugs of steroids in your body, and a lot of people are anti-steroids. Okay, fine. I'm not trying to fight that battle today, but steroid injections for spinal stenosis, for shooting down pain, numbness, tingling, have an excellent track record. At minimum, the mean clinical improvement is at least 60 to 70% get better with steroids and can avoid surgery for a significant period of time. And that's a big deal. Again, appreciate all the likes coming through. That helps promote this to the peers. So if you guys can keep hitting that, keep sending this to other people, the follows, that really goes a long way. What would happen if cement got in my spinal canal and cannot be removed? Colon, it might be fine. I guess the cement would get in your spinal canal for a couple different reasons, but honestly, it's all about the compression. If it's in there and you know about it, if it's not causing an issue, then it's fine. It probably will never cause an issue. If it, gets the cement and kind of pushes up right here, and then you get arthritis pushing down, then probably just something called a laminectomy would fix it. So not downplaying it, but it's not something where it's like a major go fix that in the middle of the night type of deal. I'd be more interested to know why this cement got in the spinal canal. Sometimes that's from a kyphoplasty, like when you have a vertebral body fracture and it leaks back. It's not unheard of in terms of complications or things happening. Sometimes that just happens. It's just you have cracks in the bone, it leaks back there. So you just try to do that procedure very slowly, methodically, carefully. Where am I at? I'm in Dallas, Texas. That's the same city I was born and raised in. And then I had 11 years after college where I wasn't here. And after a decade plus of my parents getting older, my wife's parents getting older, my friends excelling and doing everything, finally moved back home to my city where I can start enjoying the nice things of being back home. Hold on really quick. I got one kiddo sleeping, so just checking on him. So I have to go really abruptly. That's because he woke up. Lindsay, retrolisthesis is a normal physiologic variant. That's when your spine, instead of anterior listhesis moving forward, it moves backwards like that. Making a long story short, it's probably okay. It's probably your body trying to put your spine into better alignment. It's not an indication for a fusion. It is not an indication for a surgery, just having that. What does it mean from sunshine and sparkles? What does it mean if the thecal sac is empty? I don't exactly know what that means. If the thecal sac is empty, I don't know what that means. I have to know more context of that. Like your thecal sac is not empty. There's nerve roots in it and spinal fluid in it. So I just have to know more context, but I don't know. Can we talk about the SI joint from AHC? We can. I wish I had my other spine model here. I'm actually not too darn sure where it is. You know what? I have a spine book here. Maybe I could open up this spine book and show you a picture, because there's probably a lot of people at home where a picture is worth 1,000 words. So give me 20 seconds. I'm going to just see if there's an SI joint in here. And then in terms of SI joint, it's funny. 20 seconds. Okay, 373. So the sacroiliac joint is the joint kind of above the hips. It's what connects your spine to your pelvis. Is this going to work? Golly, there's some pretty interesting pictures. Okay, I don't know if I'm loving showing this picture. It doesn't show a ton, but here's like an MRI, a CT of it. So it's like if you're looking down the tunnel, that is the SI joint right there. And you can see there's different fixations and whole different plethora of things in there. I don't really like showing that picture. That didn't do much. Look, the SI joint is kind of this. You have another bone here. That's the pelvis. In terms of the SI joint, patients can hurt it from traumas, pregnancy, and just a degenerative condition. The reason the SI joint sucks and it's really hard to figure out what's causing the pain is that's totally based on the clinical diagnosis. There's no, for the most part, no radiographic evidence to show you when you're having an SI joint issue. There's not a CT, an MRI, or an X-ray that has been shown to prove you're having SI joint issues. So the reason I say that's tough is because if you have like a disc herniation and you get an MRI, boom, you see it, you know it. So the way you figure out if you have SI joint issues is one, a clinical exam is the history. A lot of people describe it as not just like pain all over their back. It's like one specific point, kind of one point. They're like, it's not here, it's here. Stairs make it worse. Getting out of bed first thing is kind of worse. Another thing is if you get an MRI and if the rest of your spine is clean, so the rest of your spine looks perfect, well, the pain's got to be coming from somewhere, maybe the SI joint. The most reliable way, and the way that I recommend highly that patients get it diagnosed, is getting a steroid injection in the SI joint. They should get pain relief pretty much immediately. If the pain comes back, okay, that stinks, but now at least you know your diagnosis. In terms of the fix for it, you got to get at least one injection and prove that that's your diagnosis. You got to confirm the diagnosis is what I'm emphasizing. And then you get an SI joint fusion. If anyone needs an SI joint fusion, there's one person. There's probably hundreds that are great at it. Don't get me wrong, but I recommend two things for that. One, make sure a spine surgeon does it. And if you're thinking at home, what do you mean that a spine surgeon? Who else would do it? Pain management doctors are allowed to do SI joint fusions. I support pain management doctors. I don't love the idea of pain management doctors doing spine surgery. So recommendation one, make sure a pain doctor is not doing your spine surgery. Make sure a spine surgeon is doing your spine surgery. Point two, if you're anywhere in the greater Texas area or something like that, and you want care for your SI joint pain, I think one of the experts that I've known and know him, he's one of my best friends. If you want to write this name down, is a guy named A.J. Rush. Letter A, letter J, and then Rush. My little boy's freaking out because he loves AJ too. Jack, come say how much you love AJ. So AJ Rush, he's kind of my SI joint expert. How much do you love AJ?
I like him because he eats pasta.
Yeah.
And he likes the Dallas Stars.
That's true. Okay. Anyway, so if you have any SI joint issues, that's something I work up and I take care of. But in terms of the surgery, I used to do it, but now we hired my best friend and I let my best friend AJ do those. From Stan Wolf, do I accept Aetna HMO? I'm in San Diego. I don't think we do. Sorry, we don't accept any HMOs. I think there's one HMO we accept. I don't know if it's Aetna though. In general, I think Aetna is the worst of all the insurance carriers. It's just crazy. I did a peer-to-peer last night at 7:30 at night p.m. Like I was like, didn't even know it was coming in. The doctor, she was getting into her car. I heard her Bluetooth and all of her car going off. And I was like, is this the most appropriate time? Like, do you even have the patient's chart? She's like, I do. Like I had to plug into my computer because my laptop was dying. I'm like, you're in your car. You can't appropriately review this patient's claim. And at the end of the day, like I have to suck up to them because they could just say no and there's nothing I can do about it. So fine, we did the peer-to-peer and she wanted to approve a certain type of cage in the neck because it's not in their guidelines. And she's just driving and it's just, I guess it just bothers me because they're not good at their job usually. And that's why they do peer-to-peers. If you're a really good spine surgeon, then you should be taking care of patients, not working for the insurance companies. And it just bothered me that like she's calling me at 7:30 at night and she's like, well, if you don't like it, you can always appeal. That's a lie. You can appeal, but that leads to maybe a 30 to 60 day denial period where now the patient can't have surgery. And the patients are usually already booked for surgery. The insurance companies wait like 2 weeks before just to, pardon my French, screw you so that they know you're going to say yes. And I'm just like, fine, I'll use your substandard cage because that's all the insurance company is going to pay for. And it's just such a sham and it's such a problem. And I'm happy to talk a ton more about it, but Aetna's the worst. Cigna's right behind them. Then United Healthcare. Blue Cross Blue Shield is actually the best right now. They are, you say you need something done and they usually take care of it. So I know everyone's a little different in terms of their experience with insurance companies, but like Aetna is the absolute worst. Cigna's not much better. And then United Healthcare used to be great. I actually used to say there's the Dr. Glaucoma Flocken who would always put up the videos about United Healthcare. And I'd say, hey, they're actually the best. I like them, but I guess things change. They have board meetings and they try to find more ways to make more than $1 billion worth of profit. So it's crazy, but I'm not going to keep talking about it. Mutual of Omaha. Yep. I'm pretty sure we take that. Not sure. Anyway, kind of got off on, I think so. Cigna Healthcare, not good. From a spine surgery and approving things that I think patients should get. No, I don't think they're good. From like, are they good humans? Yes. So I don't want to get pickleball into that, but from approving things I think my patient should use, yes. All right, so let me kind of get back on the thing. Am I a believer in spinal cord stimulators from Blake? I have a mixed thought on it. My thought is I think spinal cord stimulators have a role. Granted, I'm not an expert on them. That's more pain management. I think it's good for patients that have neck pain or back pain and either can't get surgery for some reason, or we just don't exactly know what's causing their pain. I think that is the best role for them. If you're having numbness and tingling going down your arms, going down your legs, spinal stenosis, that would be a really good role for injections or surgery. So they aren't FDA approved. I don't know if that's the spinal cord stimulators that aren't FDA approved. That'd surprise me, but I don't know. There's a lot of things we do in the world that aren't FDA approved that I'm not trying to go down the whole FDA approval debate, but there's a lot of, I think epidural steroid injections aren't FDA approved, but there's thousands of papers that show that they're effective and good and they're safe. Can you have an issue? Yes. But if it was me, I'd have 10 injections before I had spine surgery just because of what the data shows. And they might not be FDA approved, but there's probably a lot of things out there we use that aren't FDA approved, but we know using them off label has excellent outcomes. Let me get to a couple more questions and then I have to run. I got kids waking up, and I actually have one of my best friends who's my anesthesiologist anesthesiologist coming over to hang out, and that's kind of nice. So that's kind of a nice part about my spine care even is that I don't just show up at the hospital and it's whatever anesthesiologist the hospital has contracted shows up, and you don't know their name, they don't know your protocol. I actually, in Dallas at least, we get to kind of pick your own anesthesiologist. It's called open anesthesia. You're probably at home wondering, is that not everywhere? Is that not how it is where I'm getting my surgery? No, if you're getting your surgery at name a major hospital corporation, they have a contract. The hospital makes money on anesthesia. And so you just get whoever is there that day. You might even get a CRNA, who are great, and I support CRNAs. But kind of the nice way about the care I give, kind of the concierge care I give and my partners give, is that we pick our anesthesiologist. So, if they're not doing good, if they're slow, if I don't think they're the best, I can just not use them again. Similarly, you can develop a friendship with them. It's someone they trust. They have a vested interest in getting the patient to sleep fast, waking them up efficiently, and just really having ownership in it. They're not just clocking in and clocking out at a certain time. They're there. They're your friends. And so kind of getting off on a tangent there. But yeah, my friend, Dr. Schraz is coming over in about 50 minutes. So I do have to go kind of clean up a little. And his wife and my wife and all of us are just going to hang out because that's kind of the nice thing. So got a nice comment from user saying, Dr. Donnelly operated on me and my wife's back this year. Good work, professional, great staff. Thank you, my friend. I appreciate you saying that. Mild cervical myelopathy. Thoughts from Angela. Angela, if you have mild cervical myelopathy, that is definitely not an indication for a surgery. Mild myelopathy, I guess that depends on how you define mild myelopathy. I define it on a score called MJOA. If you go online, you can fill out an MJOA score and you can see what your score is. If you have MJOA above 14, then you have mild, and that's not a surgical recommendation. Even if you have moderate, that doesn't necessarily mean you should do surgery. So there's a whole lot of things there. Okay, from Roscoe, why don't surgeons focus more on painful annular tears? It's only disc replacement or fusion. Dr. Kim does, sorry, there's a little heart next to your name, so I can't, what was I going to say? Work on annular tears. Wow, I have a lot of questions or things to say. I like Dr. Kim. He's one of my friends, and he does great work. My next topic that's totally unrelated is there's a lot of doctors out there that will operate for cash, and that's great. And if you're operating on cash for annular tears, I don't think he does annular tear surgery, so I'm just going to move past that. Dr. Kim's great. I'm not going to comment more on the annular tear surgery. What does a calcified disc herniation indicate? It indicates that the disc herniation has been there for a long time and it's laid down bone to calcify. Do I accept Cigna? I saw you in the camera. Do I accept Cigna? Yep, I do. All right, everybody. On that note, I'm going to go play with my kiddos. I do telemeds. We're going to go play hockey. Let me just say bye. I do telemedicines all the time. You can direct message me. I'm in Dallas, Texas. Send me your information, and I will just have my staff or myself send you an automatic reply. This is Jack. He's been so patiently waiting for me, and that's why I don't jump on these as much anymore. See if you look there. See you looking.
Oh, yeah.
Anyway, so yep, I like doing these on the weekend, but as importantly, I like playing with my kiddos. So that's why I don't do these as much anymore. But I think it's good to have an opportunity to ask a spine surgeon or a healthcare professional questions about your own health, about 2-level ACDFs, about disc replacements, about spondylolisthesis. So that's why I use social media. I think it's a good avenue to connect with patients and help. If you live in a small town and there's one mean neurosurgeon in town, that's your only option, and that stinks. But COVID showed us that telemedicine is a great option to take care of any health issue. That's something that's really skyrocketed my practice, is doing and just taking care of it. So my kids sometimes like it. They also like to go to school and have nice things. So
I don't even like to go to school.
and he doesn't like going to school. So
School.
it's good to do social media, but it's also time away from the family. Okay, on that thing, I do have to go. I thank everyone for reaching out and talking.